Welcome everyone to the eMedica MSRA Masterclass for the 2021 MSRA. We're going to do some high yield revision this evening. Okay, so the format, what we're going to do today is we're going to start with an overview of the exam and how it will be used, but the main focus is high yield revision. So we're going to do exam style questions for the clinical and SJT paper. We're going to talk about revision planning. Why do people fail? And then what can you do to succeed and to avoid those things? What will not be covered today at all are any questions to do with the applications, how to apply, the eligibility to apply for specialty training. And that's because that's completely outside. This is for MSRA. We've got a whole other course for how to get into GP training, including detailed step-by-step how to do the application. I've posted on our YouTube channel various videos on how to rank areas, how to actually fill in the application. Feel free to look at those. That's just not for today. Okay, today is about the MSRA. Right, so let's go look at what we're going to cover. So we're going to start with an introduction to the exam and how different specialties are going to use it. Then we're going to do some revision questions for the clinical paper, then for the professional dilemma paper. Then we'll look at why do people fail, how you can avoid that, how to prepare effectively for both papers. So you don't just get a job, you get your first choice job. And then we've got a live Q&A at the end, and we should finish at 9:30. Okay, so if we start with the basics, the MSRA, the Multi Specialty Recruitment Assessment, is an assessment used for recruitment for ST1 or CT1 level posts by lots of different specialties. Okay, there's venues worldwide. After you submit your application, you'll get an invitation by the 5th of January to actually log in and book through Pearson VUE to a test center. Okay, most of you will do it at Pearson VUE. Some of you, if you're shielding or there's local restrictions, you can't get to a center, you can apply to sit it at home, but that's only if, because of COVID restrictions, you cannot go to Pearson VUE. The dates for the actual exam are from the 28th of January to the 12th of February 2021. That's a bit later than normal. Normally it's early in January. So it's good, we give it a bit more time to prepare. And once you get the invitation around the 5th of January, you'll be able to log in and pick which date you want to sit it and which center you want to sit it. Hopefully there's one close to you. There are Pearson VUE test centers all over the world. Okay, so the whole assessment is done in one sitting. It's 2 hours and 55 minutes, including the break. So there's two parts. The whole thing's done on computer. You will always have the professional dilemma paper first. That's the SJT paper. That's 95 minutes. Then there's a 5-minute break. Then you immediately start the clinical problem solving paper, which is 75 minutes. And there are multiple equated test forms. What does that mean? Well, look, some of you might have applied for more than one specialty. You might have applied for GP, psych, various specialties. We'll look at that in a minute. You only sit the exam once. The same score will be put in through Oriel to all the different specialties that you've applied to, but every specialty uses it in a different way. For example, a score that might get you a job in one specialty might not even get you an interview in a different specialty, which is more competitive, okay? But because there's going to be thousands of doctors sitting this exam on different dates across a 2.5-week period, even on the same day, you all have different questions. So when you click start, you will randomly be allocated one of many different versions of the exam. Now, all the exams have the same proportion of different questions and different types of questions, and the same level of easy, medium, and hard questions. That's why they're equated test forms. Do you see? That's what we mean by equated. But the person sitting next to you on the same day will have different questions. That's because if it was the same questions every day, you see, people that sat it by the last day on the 12th of February, they might have found out some of the questions, and some people might feel they've got an unfair advantage. Okay, so the questions are all different, not just on different days, even on the same day, the person next to you will have different questions. Okay, so that's an overview, the basics of the exam. Let's look at how different specialties are going to use your score, and I'm going to just introduce you to the poll. So I'm going to launch the first poll. Okay, and there's 3 specialties that are new this year to MSRA. They've never used it before. They are Pediatrics, Anaesthetics, and ACCS Emergency Medicine. These 3 specialties haven't used this before, whereas the others on this list, they have been using it for a few years, and GP is the original specialty that used this. That's why this exam used to be called the GP Stage 2 exam. Okay, now why is it called the Multi Specialty Recruitment Assessment? Because so many different specialties use it. So if I just close a poll, what I can see is that the most popular specialty amongst people that are joined today, nearly half of you have applied to GP, and maybe as one of your specialties. A lot of people apply to more than one. After that, really popular ones are Anaesthetics, Radiology, Obstetrics, CSRH, Psychiatry, and then slightly less people, ACCS Emergency Medicine, Peds, Neurosurgery, very few, but there are very few jobs for Neurosurgery. So as I mentioned, if you've applied to more than one of these, you won't sit the exam more than once. You'll get one date that you book for the exam. Whatever you score, the same score will automatically via Oriel go into each specialty's application. But how each specialty uses it is completely different. And I'm going to show you that now. Okay. Now, one of the things that some of you might have found frustrating is that there is not a lot of information, especially for the new specialties. And even as of today, I've checked, some specialties still haven't released exactly how they're going to use a score as of today. And, you know, the applications are closing in a week. The ones that I know for certain, I've listed here. The ones that there is no information available about the full details, I'll tell you about that. So the first thing is GP. GP and psychiatry, Child and Adolescent Mental Health Service, follows the same route as psychiatry. Both these specialties, there is no selection center, there's no interview this year at all. And so 100% of your rank is going to be based on how you score in MSRA. Nothing else will make a difference as to your chances. There's no portfolio, there's no virtual interview, nothing. 100%. So I've listed them by order of how important the MSRA is in terms of the ranking. Now, clinical radiology, it's 33% of your total. Okay, in all of these, the rest is either interview or interview and portfolio or interview and self-assessment. The interviews are all going to happen via Microsoft Teams or Zoom, you know, remotely, no physical interviews at all this year. However, with radiology, although it's 33%, two things about radiology. One is that they only tend to interview the top 600 scorers. Like last year, 1,000 people applied. They only interviewed 600 for about 300 jobs. This year, there might be slightly less interview slots, okay, because they're doing them remotely. But the other thing is that this year, radiology, if you can be in the top 55 scorers amongst the radiology doctors, okay, so, you know, if 1,000 people are going to sit the exam for radiology, the top 55, basically the top 5%, then you can skip the interview and get a direct offer. Radiology has never offered that before, but they are this year for the first time, okay? So there'll be no interview. They'll still look at your portfolio, but there'll be no interview, okay? Obstetrics, as of today, when I checked the website, you know, the most recent time I've looked at it, it said that it's still not confirmed exactly how they're going to use it, but all of the last few years, it's always been 25% of your total rank. And also obstetrics this year have said that if you score really, really well, it will also be possible to get a direct offer without interview on obstetrics. What they haven't said is what will be the cutoff, you know, how many will get that. They haven't said that. They've not released that yet. They've said they'll release it at some point, possibly after people have submitted all the applications. Neurosurgery, it's 40% of your total. So again, it's significant, okay? Pediatrics, there's two options. Plan A is that all the interviews will be able to go ahead remotely and it will be 20%. If there aren't enough consultants to do the interviewing, then they might shorten the interviews, change the format of the interviews. So Pediatrics' Plan B is that the MSRA will be 40%. So Plan A is 20%. Plan B is going to be 40%. Anaesthetics is just 15%, but Anaesthetics will use the MSRA as their main shortlisting tool, i.e., let's say that they're going to interview, you know, so many hundred doctors, so many hundred will get that slot for interview. And then once they get there, you know, the bulk of your marks is going to be about your portfolio and interview. But if you don't score well, you're just not going to get one of those interview slots because anesthetics is really, really competitive. Typically 2.5 to 3 doctors for every one job. Ophthalmology, similarly, it's only 13%, but there's limited interview slots. So if you don't do really well, you won't get one of those limited interview slots. If you do, the bulk of it is the rest of it. And then ACCS Emergency Medicine, even as of today, they haven't confirmed. I looked at both the main ACCS website and on the LAYS website, who are handling the ACCS ST1 for emergency. Both of those still haven't confirmed the percentage that it will be for emergency medicine. None of the official websites or applicant guides have listed that yet. So it's, you know, to be confirmed for emergency medicine. Okay. Again, it's maybe because it's new this year. Okay, so let me explain how the scoring works though. In all specialties, the clinical problem solving paper and the SJT, both papers are equally weighted. Now, this is also something that's different because historically in GP, the SJT used to carry more weight than the clinical. But this year, all specialties, clinical and SJT, are worth the same. They're equally weighted. So initially, your raw score will be allocated to a band between band 1 and band 4. Generally, Band 1 means you've failed and you cannot progress. And Band 4 is a top band. But they will turn your raw score into a standardized score based on how you do compared to others. I.e., it's not just about your score, it's about your score compared to everyone else. The mean score for the whole cohort will be converted to a standardized score of 250. So if you score more than 250, it means you scored higher than the mean. If you score less than 250 in either paper, it means you scored lower than the mean. Okay, that's what that score means. And this is historical data we've collected over more than a decade of teaching for this exam, that generally how many people end up in which band. So in most specialties, if you get band 1 in either paper, even if you get 100% in the other paper and do really well overall, you will be deemed to have failed and won't go further. Okay, in most specialties. Okay, band 2 is the minimum, therefore, usually to get a rank. But in a lot of specialties, especially the competitive ones, if you get 2 band 2s, you're just not going to get an interview. You may not get a job, or you may not get the job you want. Okay, band 3, can you see at the bottom end of band 3, you're still below the mean. 250 is the mean, remember. You're in the middle band of band 3, you're above the mean. You're in the top band of band 3, you're significantly above the mean. You're in the sort of top third. And then band 4 is really the top 15% odd. Okay, that's where you want to aim for. All right. Now, in terms of the outcomes after the MSRA, there's 5 possible options. If you're below the cutoff for your specialty, you will be deemed to have failed. So, like for example, in GP, in psych, if you get a band 1 in most specialties, if you get a band 1 in either paper, you get an email to say you're below the cutoff, you're not deemed suitable for training based on your assessment. You could reapply in round 2 and resit. A lot of the popular specialties, like radiology, fills 100% of their jobs in round 1. Similarly, anaesthetics, so there just won't be a round 2. What it means is apply next year. Some specialties, like GP or psych, will have a round 2. The exams for round 2 are in September 2021. That's for jobs to start in February 2022. So you could resit if you failed. You could get an email to say you were ranked, but for those specialties where there is an interview that you weren't shortlisted, i.e., like radiology, let's say now you rank 650th, and they're only interviewing the top 600. You get an email to say, look, here's your score. You ranked 650 out of 1,000. We're only interviewing 600. Sorry, apply next year. Okay. Or you could get an email to say, congratulations, you scored this, you've been shortlisted, log back into Oriel and book a slot for interview. The interview will be remote, but you still need to book a timetable, an appointment. For specialties that there is no interview, like GP, like psych, where it's entirely based on this score, if you don't score well, if you're not competitive, you could get a rank, but no offer. So you might get an email to say, look, you ranked 5,000 for GP, for example, where there's more than 5,000 people going to be sitting the exam probably, but there's only 4,000 jobs, so we can't give you any offer. You're on the waiting list. From the waiting list, if some people reject their offers, you may get a job later, you may not, in which case you'd apply again, and you could this year resit the MSRA in September for round 2 to try to improve your score. Previously, that wasn't possible, but they're going to allow it this year. Or you might get an email to say, look, we'd like to make you an offer in this area. You can only get one offer for each specialty. So you can't get offers from multiple areas for any one specialty. You could get a different offer from a different specialty, but each specialty will only give you one offer. Your highest preferenced area, you move the areas to rank. Some of you will do that ranking a bit later, okay? But you will select the areas that you want based on your genuine preference. You will get an offer from only one place, your highest ranked area that had an empty slot when they got to your place in the national ranking. And then, as I mentioned, for GP, for psych, the offers are 100% based on MSRA. For radiology and obstetrics, if you do really, really well, it is possible this year to get a direct offer without having to do the interview. So these are the possible outcomes after MSRA. So what our job is, what our team are here to do, we want to help you either get this job offer or get a direct offer, even better. Okay, that's what we're here to do. Okay, so that's an overview of how the different specialties are going to use your score, right? So I'm going to move on now to, let's get on with some high yield revision, okay? And then, as I said, questions and answers we're going to take at the end. Feel free to ask them. What I would recommend you do is don't start asking questions now. Write them down at home. A lot of your questions are going to be answered because I'm going to cover it in the how to prepare and things like that, okay? So the clinical paper is 75 minutes, and in that time, you're going to answer 97 questions. Only 86 carry marks. There are always 11 questions in every paper that are pilot questions. You won't know which ones they are. They won't look any different. They won't be labeled with an asterisk. They're there for research purposes, to pilot new items, but also for quality assurance. So you have to take all 97 questions seriously, but some of them carry 0 marks. You just won't know which they are. Now, there's 2 main question formats: extended matching questions and single best answer questions. This makes up about 95% of the exam. Okay, 95% of the exam. There may be some of those questions that have an algorithm where you might actually drag an answer into the right slot. There might have one or two that might have a picture, and there may be one question or two questions in the whole paper that are multiple best answers, where there's more than one correct answer. But in most cases, you're going to either do extended matching questions and single best answers. Now, they're not mixed up. All the EMQs are together and all the single best answers are together. What is this level of knowledge being tested, and what are the topics covered? Well, the level of knowledge is the level of knowledge expected of an F2 who's just started F2. I'd expect you to be able to manage patients, to be able to come up with initial management plans, to know how to deal with emergencies, to make your own diagnoses. It's not like finals where they know that you've got the theory, but you've never actually practiced. You should already have been practicing for more than a year at the stage that you're sitting this exam, all right? So that's the level of knowledge of an F2. And in terms of the topics, these 12 groups are evenly split in the exam. So there'll be roughly as many cardiovascular questions as there will be infectious disease, hematology, immunology, allergies, genetics together. All of this together is about as many as this in terms of how many questions there'll be. So these are the 12 groupings, if you like, and there's going to be questions spread evenly amongst all of these, okay? So let's do some questions. We're going to do a set of 3 MQs, okay? If you think about 97 questions in 75 minutes, that gives you about 45 seconds per question, okay? So I'm going to get you to do 3 questions in one go. So what will happen is you will see 3 questions. The screen will move forward automatically. Just write down your answers at home. After you've done all 3, I will launch the poll for each question at a time, and we'll go through the answers. You'll see why we do it like this. If I give you the answer to the first one and explain it, it might help you work out the answers to the second and third one. In the exam, no one's going to explain it in between, are they? Okay, so all 3 questions are going to start. They're going to do one after the other. Here we go. Okay, so we're going to use the poll now. That's time, okay? So I'll show you the question, and then I will launch the poll for each one, okay? So, okay, that's enough to get an idea. Okay, so I can see that most people, 80% picked A, angiotensin converting ACE inhibitor, okay? Followed by C, calcium channel blocker. Okay, so the correct answer here is A, ACE inhibitor. Why? Okay, so this patient is 45, otherwise fit and well. Why do we care about that? Why? The main thing we're looking for is which condition. Have a think about that, because we'll see a patient in a minute with it. And then the other thing we care about, because it can make a difference to the answer, is ethnicity, and his ethnicity is Asian Bangladeshi. Okay, and so the correct answer here is ACE inhibitor, because if someone's under 55, or if they're diabetic, now they're not diabetic, but if they're under 55 and they're not Afro-Caribbean, then it's going to be an ACE inhibitor first line, an A-class drug, and normally the first line A-class drug is an ACE inhibitor. So that's why it's an ACE inhibitor. Okay, let's do the second one. I'll just launch the poll again. So this one's a 54-year-old Caucasian patient, and he's got stage 2 hypertension. Again, no other medical history of note. He's not on any medication. So what we're going to prescribe for this patient. About 80% of you picked A, ACE inhibitor, and again, about 15% picked C, calcium channel blocker. All right, okay. The correct answer is A again. Now, be honest, type in the chat, is there anyone that actually thought it was an ACE inhibitor, but then they thought, I've just put A and I don't want to put 2 A's in a row because I think they're trying to get me. And you actually, even though you knew the answer was ACE inhibitor, because this is a Caucasian patient and they're under 55, that you changed it because you overthought it. Just type that in the chat if there's anyone that did that, because I just want to highlight a little bit about exam technique. You know, part of doing well is knowledge. You either know the guideline, have done the reading, or you haven't. Part of it, though, is exam technique. And so sometimes there's some people who they think that, and then they actually, you know, they're confident. I've treated a patient like this. This is what I would do. But then they overthink it. They think, you know what? Why would they put 2 A's in a row? Nobody's trying to get you. We want you to succeed. We want you to get into specialty training. We want you to finish your whole training, get your membership, get your CCT, come and help us on the front line seeing patients. That's what we want. Okay. So it's really important. If something seems easy, remember this: everything is easy if you've done the work and you've learned it. Okay. Prepare and you will succeed. All right. Let's do the third one. Just launch the poll again. Okay. So that's really, really interesting. This time we've got just over a third picked ACE inhibitor again. The bulk of you, nearly 60%, picked calcium channel blocker, and then there's a spread between, you know, various other options. So not many people picked any of the others. Okay, these were the 2 big ones, A and C. The correct answer here is B, angiotensin 2 receptor antagonist, ARB. Okay, and that's because this patient is both Afro-Caribbean, being of Nigerian heritage, and he's diabetic. Okay, and there's another clue that he's diabetic. He's on metformin. Right, in case you missed it here. There's another clue there. He's on a statin and he's on metformin. Okay, and this highlights the importance of being up to date with your guidelines. All right, so just go through the guideline. The most challenging part of this guideline, this is the NICE Hypertension Guideline 2019. Okay, is the first step. Step 2, 3, and 4 are very straightforward. Okay, once you've decided someone needs medication, which all 3 of these did, the first question you want to ask is, are they diabetic? Because if they are, no matter what else, they will need an A-class drug. Ethnicity can change what that A-class drug is, but it will always be an A-class drug. So A-class is either an ACE inhibitor or an ARB. Okay. If they're not diabetic, the next question to ask is, are they Afro-Caribbean? Because if they're not diabetic and they're Afro-Caribbean, regardless of age, it's going to be a calcium channel blocker. If they're not diabetic and they're not Afro-Caribbean, then third question is, how old are they? If they're under 55, it's going to be an ACE inhibitor. If they're 55 or more, it's going to be a calcium channel blocker. Now, whichever one you start them on in step 1, optimize that. So for example, let's say you started someone on lisinopril here. Optimize the dose of that. In step 2, the new guideline is you could either give a calcium channel blocker or a thiazide-like diuretic. Similarly here, you've optimized the calcium channel blocker. Step 2, either give an ACE inhibitor or a thiazide-like diuretic or an ARB. Remember, A is either ACE inhibitor or ARB. Optimize both. Step 3, they're going to be on 3. An A-class, calcium channel blocker, and a thiazide-like diuretic. Still not responding. Step 4. Think about more diuretics, so things like spironolactone. Think about alpha blockers, think about beta blockers. Still not responding, probably going to be seeing a specialist for resistant hypertension. Okay. Now, something also new in the new guideline. Patients of Afro-Caribbean heritage, if they ever need an A-class drug, i.e. here, you should give them an ARB, not an ACE inhibitor, because the latest evidence is that there's a better response. So if we go back to this patient, you see, they're Afro-Caribbean and they're diabetic. So they need an A-class drug, right? Because diabetic, you need an A-class drug. But because they're Afro-Caribbean, A means ARB, not ACE inhibitor. So do you see why B is the right answer? Okay, so it's ARB. Okay, good. We're going to do one more EMQ, then we'll do some single best answers. So this one's going to be about investigations. Here we go. about half of you have picked A, urine dipstick. About 40% have picked B, urine culture and sensitivity. And then a few people have picked things like DMSA scan, CT abdomen, Usenes, all of the others, very few people, okay? But the really popular ones are urine dipstick, and then, so urine dipstick was the most popular, about half of you, and then followed by urine culture and sensitivity, okay? So if I look at the correct answer here, is going to be B, urine culture and sensitivity. Why is that? Well, this is what we call a two-step question. In a two-step question, the first step, this question is about investigations, but the first step is to work out what is the diagnosis that we're trying to confirm. So from the symptoms of dysuria, nocturia, and urinary frequency without being thirsty, just type into the chat, what is it that we're trying to look for? In this particular patient, what is it that we're actually trying to confirm? You see, the first step in a two-step question is always very straightforward. They're not trying to catch you out, okay? Can you all see that what we're trying to sort of look for here is a UTI? What is the most discriminating test? What does that mean? It means for this patient, what is the most accurate test? If it said, what would be a suitable initial test, that keyword, that urine dipstick is great for that, but it's not very accurate, okay? Because a urine dipstick, it can tell you, are there leukocytes, are there nitrites, is there blood? Based on that, you might work out that there's a good probability, a low probability, a fairly high probability, but it doesn't tell you for sure that it is. A culture and sensitivity is much more accurate. It tells you it definitely is an infection. In fact, it's this bug, and this is how you can treat it. It's much more discriminating. What does most discriminating test mean? It means the most accurate test for this patient in this scenario, okay? Now, keywords like this make a huge difference in terms of exam technique, okay? That where people either in a rush, they misread a keyword, or they misunderstand what the examiner is testing, they will often get it wrong, okay? There's also many patients where there's a higher chance that a urine dipstick will be inaccurate. A good example is someone who's acutely unwell, someone who's been recently catheterized, someone who's over 65, someone who's pregnant. Urine dipstick often is unreliable. Generally, it's nowhere near as reliable as a culture and sensitivity in terms of accuracy. And that's what this means. It means the most accurate test. It is important here to read the symptoms. Okay, so we're trying to discriminate between someone who's got a UTI and someone who hasn't got a UTI. For that, urine culture is the best. We're not trying to separate between someone with a UTI and someone with diabetes, because someone with diabetes isn't going to have dysuria. Do you see? So paying attention to the symptoms to work out the first step is really important. We're trying to separate between those that have UTI and don't have UTI here. And so for that, the most accurate, most discriminating test is urine culture and sensitivity. Let's do the second one. Okay, so again, big spread with this one. So we've got the most popular answers H, abdominal ultrasound. Then we've got E, DMSA scan. And then we've got C, a KUB X-ray. Okay, and then all the others, very few people, just a handful, one or two people. But these were the three popular ones. The most popular one is H, abdominal ultrasound. Okay, the correct answer here is E, DMSA. Now, the key word here is most appropriate. What does that mean? It means most appropriate for this patient in this scenario. Okay, what's the scenario? Someone with recurrent UTI, multiple UTIs over a 1 year period, so recurrent UTI, and her last episode ended 4 months ago. Okay, that is very, very important. She's well in herself at the moment. You see, she's well in herself at the moment. There's no indication to do a urine dipstick or a culture or things like that. Okay, so it's really about imaging to look at long-term damage, to look at what's happening with the kidneys. So the reason that my answer is E, DMSA, is that this child is 4. So the guideline for people who are 3 and above and have UTIs, most children need imaging, okay, of one sort or another, is based on that. If they've got recurrent UTIs and it's 4 months, then what they need is a DMSA scan. They would need an abdominal ultrasound, but not at this stage. Can anyone type into the chat, when would you do an abdominal ultrasound in a young patient with a UTI or with recurrent UTI? Anyone type in the chat? When we do that, if you've done peds, you know this because you'll be doing lots of them. Okay, so if it was an atypical UTI, you'd do it acutely while they've got it. If it's recurrent UTI, you do an abdominal ultrasound a bit earlier than this, usually within 6 weeks, but not 4 months later, okay? 4 months later, what you need to do is do the DMSA scan. DMSA stands for demercaptosuccinic acid. That's no one knows how to say this one, so that's why everyone just calls it DMSA. Okay, so over 3, an atypical UTI, you do the ultrasound during the acute infection, whereas recurrent UTIs, you do it an ultrasound within 6 weeks, but the DMSA scan 4 to 6 months after the acute infection to look for things like scarring, long-term damage, what's happening. Okay, and so that's why the right answer was DMSA, because it was 4 months later. But let's do some single best answers. What I can see there is the 2 answers that are really popular are B and C, hyoscine hydrobromide and dexamethasone. They're both about a third each. And then after that, all of the other options have been picked by varying degrees. Okay, the next most popular one after that was haloperidol. Okay, now this is another important question in terms of technique, because this is what we call negatively framed. The majority of questions in your exam will be positively framed. You'll ask which is the best option, which is the likely diagnosis, which is the most appropriate treatment, things like that. But there are sometimes a few questions which are negatively framed, i.e., which is the least helpful, which is the least likely diagnosis, which is something, i.e., what would you not be doing? So least helpful doesn't mean it won't do anything. It's just the least helpful compared to the others. So again, what we've got here is someone terminally ill, they've got metastatic cancer, and they've got now severe nausea and vomiting. Now that could be because of the progression of illness. Lots of patients with cancer have some symptoms like that. But sometimes a recent onset severe nausea and vomiting in someone with metastatic cancer could be an indication of what? Any suggestions? What kinds of mets could cause that? Yeah, absolutely. So brain mets can very, very commonly cause very severe but quite rapid onset nausea and vomiting. So what's the least helpful in alleviating the symptoms? Correct answer is B, hyoscine hydrobromide. What's that used for in palliative care? 2 things, to dry out respiratory secretions and for someone with severe bowel colic. That's not mentioned as a symptom. Neither of those are mentioned as a symptom for this patient. Okay. You can actually use hyoscine hydrobromide in a different type of sickness, not for this type of patient. This patient is going to be in bed, right? What type of sickness can you use hyoscine hydrobromide in? You can use it for motion sickness, okay, but not for this indication. Whereas all of the others can be used especially in palliative care. So for example, levomepromazine, often you can put in a syringe driver. Cyclizine, very commonly used as an antiemetic. Haloperidol also has antiemetic effects. And then dexamethasone is often used in palliative care for someone with severe nausea and vomiting. Okay, whereas hyoscine hydrobromide would be used either to dry up respiratory secretions or for bowel colic in this kind of setting. Okay, but in motion sickness, it can be used. So again, do you see, some of you that got this one wrong, it's not because of a lack of knowledge, it's because you missed, it was asking which was least helpful, okay, rather than what would be helpful, okay? So just bear that in mind. Okay, question number 7. So I can see that the most popular answer, about half of you have picked D, and then the 2 other ones that are popular, A and B, a drug allergy or drug sensitivity. are the two other ones. Okay, the correct answer here is D. So well done. About just over half of you got that right. Okay, so well done. But quite a few people picked one of the other options. So this is called the Jarisch-Herxheimer, or just sometimes shortened to Herxheimer reaction. Okay, you get it. There's two very classic illnesses when you treat them with antibiotics that you get it. One of them is Lyme disease. Okay, I'll come on to what the other ones are in a minute. Okay, but what often happens is if someone's got this type of an infection, the reaction to having that in the body and then the antibiotic causes this specific type of reaction. Okay, typically it happens within 24 hours of the first dose. All right, in this case it happened 12 hours, and they've got the classic things that you see with it. So you often have that mild fever, facial flushing, you get a tachycardia, it causes a mild hypotension. In a very small number of patients, it causes a much more severe reaction. It can cause very severe hypotension. Okay, but here you can see that, you know, blood pressure is a little bit low, but it's not drastically low. Okay, so this is called the Jarisch-Herxheimer, or sometimes shortened to just Herxheimer reaction. Okay, so, you know, it can happen with any antibiotic treatment, but it's very common. About 15% of patients who've got Lyme disease and then get treated with antibiotics, so normally that's with doxycycline, have this specific reaction. You know, it's that common that it's one of the things we always counsel patients who we start on doxycycline for Lyme disease about. Okay, and it's basically a release of toxins by the antibiotics working and causing the death of the bacteria. But patients think, though, they're having a side effect or a reaction and they want to stop. What you need to explain is, as long as they've been assessed and their blood pressure is not too low and things like that, that actually it will just get better. Okay, so in what other infections is this reaction very commonly seen? I'll just put the chat back on. There's one other one that is really famously seen in, and then there's a couple less common ones. Okay, so the other really common one is syphilis. Yeah, so well done, most of you have got that. Okay, and then the other ones, leptospirosis, you can also get it with, and then there's various other ones that are a lot less common. There've been a few case reports, for example, with things like brucellosis, Q fever, but the absolute really common two are Lyme disease and syphilis. You must know about those. Leptospirosis is probably the next most common one after that. Okay, it's really any spirochete type infection can cause it. Okay, emergency care. The most popular answer by a big margin is B, IM adrenaline 1 in 1000, 0.3, but actually a third of you picked IM adrenaline 1 in 1000, 0.5 mils. And then we had C was the next most common after that. A few people picked IV adrenaline 1 in 1000, 0.3 mils. Okay, so this is a 9-year-old, that's important. Okay, and again, this is a two-step question. If we look at the first step, having a slice of cake, swollen erythematous stridor, you can all see that this is anaphylaxis. You see, they're not trying to get you in that first bit. So the most suitable management plan for a child who's 9, that's the key. The correct answer is B. IM adrenaline 1 in 1000, 0.3 mils, because what's going to kill you is your airway closing. So you want to get that adrenaline as quick as possible. The time it's going to take you to add in a line is delay that we can't afford. Of course, after you've done this, you will want to get a line in them, because you then want to give them things like IV hydrocortisone, IV antihistamines to manage the rest of the reaction. But we want to get that adrenaline in there as soon as possible. IM, it's standardized. It's 1 in 1000 is the concentration. And then it's just by age that you look at the volume and therefore the dose. So, you know, over 12, it's the same as the adult dose, which is 500 micrograms. So that's 0.5 mils at 1 in 1000. 6 to 12, it's 300 micrograms. So that's 0.3 mils. And then under 6, so this child was 6 to 12, you know, they were 9. Under 6, it's 0.15 mils. And you often have pre-filled syringes in these sizes. If we go back, not many people did this, but sometimes people see the 0.3 and they pick this, but they miss that this is IV. Again, that's the technique. When we give IV adrenaline, for example, in cardiac arrest scenarios, it's 1 in 10,000 concentration, okay, rather than 1 in 1000. Okay, so that's an example of different clinical questions. So we've got some EMQs and we've got some single best answers. They're the two main type of questions, okay? Now, how are you going to prepare? First thing is that active learning is going to be more effective at putting things into your long-term memory than passive learning. But there is some benefit in doing both. So passive learning, an example of that is reading. You know, reading a section of a textbook or a few pages, for example. Active learning is, if you've done that reading, making concise notes, or like we've done, by actually thinking about a question and doing questions and clicking, it makes it a lot more active, okay? What you want to do is make sure you've covered the curriculum. You can see it's a really broad curriculum. It's not that individual questions are super hard. We've done the harder end of the questions here, okay? Because I'm going to talk to you about a few topics. We've only got an hour and a bit together today, okay? Then I want to talk about things that people are going to struggle with more and hard questions to highlight technique rather than do easy things that you all get right, okay? So what you want to do is you want to, you know, mix doing questions. That should be the bulk of your learning. But also you want to then, areas you get wrong, read up a bit more so you understand the subject rather than learning that question off by heart. You're not going to get that same question. If you learn the subject, no matter what question they give you about that subject, you're going to be able to deal with that. And you're going to practice realistic questions that are in the right format and the right level. You want to work on your exam technique. And closer to the exam, it can really help to get used to the timing, because 97 questions in 75 minutes is tough. So just to get used to the pace, it's worth doing some full-timed mocks, okay? Now, the questions are all going to be mapped. We looked at the curriculum, that's subjects. But in terms of domains, all questions are mapped to 5 domains. So every question will, and we've done questions on all domains, okay? So some questions will be about the right type of investigation to do for a specific patient. Some will be about a presentation, a case, and you making the right diagnosis. Some will be about managing emergencies, the kind of emergencies an F2 should be able to deal with: acute severe asthma, sudden collapse, life support, anaphylaxis, cardiac arrest, acute coronary syndromes, all of these kinds of things, okay? Prescribing. So some questions like we did, about prescribing different drugs in hypertension, and then management, non-prescribing. So knowing, for example, who should be admitted. You've seen a patient in A&E, who should be sent back to the GP, who you can treat there, who to admit to medics, who to admit to surgeons. Part of that's going to be based on what you think the diagnosis is going to be, and then knowing the current guidelines for management. So, and sometimes management non-prescribing can also include where there might be options of a drug as one of the options, but there might also be options of not having a drug, but having something like physiotherapy or having surgery or having some other non-medication based management. Okay. In terms of if you want to do some reading, I'm not recommending you read textbooks cover to cover, but it can be very useful if you've done a question and you get it wrong to read up a bit more broadly about that particular subject so that you understand the subject. If you want to cover all of those 12 boxes that I showed you earlier, the Oxford Handbook of Clinical Specialties and Clinical Medicine will do that. Okay. For clinical specialties, the latest edition is number 11. For medicine, it's 10. 11 is due soon, but won't be out probably before your exam. Okay, 10's a few years out of date now. I think we've got ours a few years ago. And then it's worth spending probably half a day on the BNF. If you just read the first section of the BNF, about the first 15 pages, it covers prescribing in palliative care, which very frequently comes up, because remember, one of the 5 domains is about prescribing. Okay, so prescribing in palliative care, things like cancer pain management, symptom controlling near end of life, general principles of safe prescribing. And then if you can read the first page of each chapter of the BNF, the first page has a summary of the drug classes affecting that system. So the drugs affecting the endocrine system. Like, for example, there's a section on hypertension. There's a review of the main drug classes, for example. Okay. If you want to read different guidelines, because some of the guidelines in things like the Oxford Handbook of Clinical Medicine are now out of date because of when it was published. Okay. It's not, at the time, it's a great textbook. At the time, they were bang up to date. It's just that a lot of guidelines changed last year and even this year, and it was published a few years ago. If you want to read them quickly, you might find useful our clinical case cards. So, I showed you earlier that card about Jarisch Herxheimer. That was actually one of those cards, okay? So what we did is our team got together, looked at current guidelines, and then made really concise summaries. Okay, so there's 112 topic reviews, 56 double-sided cards. It's in a handy deck, so even like if you're in A&E, for example, you're on the tube, you don't need internet access, you can read it. And they're mapped to, so some are about management, some are about investigation, some are about diagnosis, some are about prescribing. But the latest set, they were only published September 2020. So they're bang up to date. For example, these are the 2020 impetigo guidelines. You can see it includes hydrogen peroxide as first line for mild. Okay, these are the current guidelines for who should get assessed for osteoporosis. These are current list of notifiable disease and so on. Okay, and then the mainstay of your revision should be practicing questions. Now, when we started running courses for what was then the GP Stage 2 exam, there wasn't a single question bank, and people were desperate for resources. So we put together the first ever bank. That was back in 2005. We ran the first course. It was the exam that predated this exam. But each year we've improved it. We get people that have scored well to write high quality questions. We've now mapped the whole curriculum. So I'll just show you how to use, whether you use ours or whether you use anyone, how to get the most benefit out of revising for clinical. So for clinical, ideally what you want to do is you want to go subject by subject. But like if you're using ours, we've mapped them to different subject headings. And like each one of these is a set of 30 questions. What I recommend you do is start with cardio 1, okay? And then if you do a question, you see every question's got a title, because in the exam, every question has a title, okay? If you get it right, reading this concise summary is probably enough for you, okay? However, and can you see, this is an example of a multiple best answer, okay? You're picking 3 things, all right? You get a mark for each one in the exam. You can see I've got part of it right. Now, where you've got it partly right or you get it wrong, that's where after reading this, you might then read up a little bit more about angina from the Oxford Handbook of Clinical Medicine, for example, okay? Now, when you finish cardio 1, don't go to cardio 2, because if you do all your cardio at the beginning, what you might find is by the end, when you come to the exam, the last time you did cardiovascular questions was 2.5 months ago. You see, instead, after cardio 1, jump to respiratory 1, then surgery 1, then ENT 1, all the way down to the bottom until you've done endo 1. Then go back to the top and do cardio 2. These are all different questions, okay? When you've done all of them by subject, do some timed mini mocks, and then we've got 3 full 97 question mocks timed, like I'll show you. When you start these, just like the real exam, it's got a timer which counts down. You can flag for review and come back to them. It won't give you any answers until you finish the whole thing. Then it will tell you your score, and then you can see the answers and allow another couple of hours to go through all of the explanations. But you do that as a timed mock to get used to and build up that stamina. Okay. It's also got 202 SJT questions, including some timed mini mocks and a full timed SJT. We'll talk about that later. So there's over one. It will take you about 100 hours. A really common question people ask: how long will it take? If you want to just do every one of those questions once, and read the explanation and do all of the mocks once, and it comes with a study guide, and read that too, it will take you 100 hours, okay? And sometimes, people might go over some sections more than once that they're less confident in, but that just gives you an idea of how big the curriculum is. You see, it's what makes the exam hard isn't that they want you to know a huge amount, like, some of the membership exams, it's the level of detail they want is huge, right? Here, they're testing a little bit of knowledge about everything. And remember, whether you're applying for Anaesthetics, Radiology, GP, Peds, there's not a different exam for each specialty. It's the multi-specialty. All of you will have the same curriculum, whichever specialty you've applied to, okay? So, one of the comments that we get year in, year out is that our questions are the closest thing to the real exam in terms of layout. Like our EMQs are, in sets, but there's only, if I just show you, there's only one per screen, just like the exam. So in the real exam, if I find it, maybe if I find an EMQ, there's an EMQ early on here. Is that, can you see, like throat problems 1 of 3, there's one question, there's a range of options. When you go to the next one, there'll be a different question, but the same options. That's exactly how it is in the real exam. And again, every question has a title like this in the real exam. So, we designed it to be as close to the real thing as possible. You can use this code MSRA 2021, all lowercase, until midnight tomorrow to get a 10% discount on any length of subscription from 1 month to 12 months. So our team will put, I'll just show you, on our website, emedica.co.uk, all of this is for specialty recruitment. So here's the online revision, okay? And then you can just click subscribe now, any period you want from 1 month up to 12 months, okay? So I'll leave that there. I'm going to move on to professional dilemma now. So the SJT is 95 minutes. And in that 95 minutes, you're going to answer 50 questions. Only 42 are marked. So there are 8 pilot questions. Again, they won't be labeled in any way. And you can see I've put in bold timing. A lot of people find SJT scenarios really tight for time, even more so than the clinical. So there's 2 sections in this paper. And there's a very different approach that you need in section 1 compared to section 2. In terms of the split, it's about 50-50. So about half the questions will be in section 1, which are ranking questions, and about half the questions will be in section 2, which are selection or multiple choice questions. Okay. So the reason that they're using SJTs is that there's good research that people's performance in SJTs has a good correlation to how well they do in the job when you compare it to essay type questions that were used before. So it's validated, it's objective, and it's machine markable, unlike essays which have to be marked by hand. And what an SJT will do is test things that can't be tested solely by a clinical paper. So it doesn't test clinical knowledge. You don't need any clinical knowledge for the SJT. What it tests is your decision-making and judgment based around work-based or work-related scenarios. Now, some of them will be difficult situations or professional dilemmas, and they will all be mapped against 3 competencies from the National Person Specification for all specialties. And they are empathy and sensitivity, professional integrity, and coping with pressure. And then some questions, if you have a good working knowledge of core GMC and ethical guidance, it will make it easier for you to answer some of those questions. Okay. So let's have a look at a couple of questions. We'll do one of ranking, one of selection. So as I mentioned, first section is ranking, second is selection. So ranking question, you get a scenario, could be based in GP, could be based in hospital. And then there will usually be 5 options, but in some questions there will be 4 options. And what you need to do is rank them, and you literally drag the boxes into the right order, okay? So 1 is the best or most effective option. If there's 5 options, 5 is the worst or least effective option. You've got about just over 1:50 per question if you want to finish the 50th question just as the buzzer sounds, okay? So less than 2 minutes per question. So let's do the first question. So I just want you to select what did you put as number 1, i.e. the best option, okay? While you're doing that, I'm just going to go over the scenario. So one of the things you want to do with SJTs is as you're reading the scenario, try to picture the scene and pick out any keywords and think about what could happen if, for each of the options, what could be the outcomes, because that's also important, okay? So you're just finishing a busy night shift, you're exhausted. Okay, you're always tired after a night shift, but sometimes it's been really busy, you're exhausted. Morning on-call doctors called in sick, and as you're leaving, basically they've asked you, can you stay on until the afternoon when a locum will be there? So they want you to cover, if it's the early afternoon and you've just finished a night shift, you can see that's going to be a good few hours, isn't it? Okay, 4 or 5 hours probably. But this last bit is very important. You are barely able to keep your eyes open and you're unable to concentrate. Is it safe for you to be seeing patients and be responsible, when you're so tired that you can't concentrate and you've finished a night shift? You already will have worked the maximum hours. No, right? Okay, good. Bear that in mind. So if I look at what people picked as their first options, there's a range. So the most popular first option is D, but lots of people also picked either E as their first option, or A as their first option. So there's a big spread, okay? So the preferred response is D, A, E, B, C, okay? D, A, E, B, C. Just type into the chat if you got the exact order right, D, A, E, B, C, because if you had exactly that order, you would get 20 marks for this question. So for the SJT, if there's 5 options, each question is worth a maximum of 20 marks, okay? So if you had it exactly right, you'd get 20 marks. But if you didn't get it exactly right, depending on how close you were to the best response, you're going to get a range of marks from 8 to 18, okay? So let me just explain the marking, and we'll come back and we'll go through why this is the right order. Okay, so this is really complex, the way that section 1 questions are marked. They're marked using something called a keyed responses marking scheme. So if you get exactly the right order and there's 5 options, you'll get 20 marks for that question. But if you get it incorrect, you're going to get anywhere between 8 and 18 marks based on how close you are. But there's always only one best order. So D, A, E, B, C is the only order that would get you 20. For example, if you had A, D, E, B, C, you'd get 18 for that. If you had D, A, E, and B and C the wrong way around, you'd get 18 for that. Whereas if you had these 3 right, but you had D at the bottom and C at the top, you wouldn't get a very good score, even though you still got 3 right and 2 wrong. It's not just about how many you got right and how many wrong. It's about how sensible is that overall order. So that's why it's called keyed responses. Every possible combination has the number of marks keyed to it. The closer your combination is to the best response, the more sensible it is, the more likely that you're going to get 18 or 16. The less close to the optimum response, the more likely you get 8, 10, or 12, okay? But if you get it perfect, you'll get 20. Now, quite a few of you put A as your first choice. Can I just ask, any of you that put A, D, E, B, C, you would have got 18, but I don't want you to get 18, I want you to get 20. Can you just type into the chat, why did you put A first and D second? For those of you that put A, D, E, B, C. Just your reasoning, please. Yeah, so I can see quite a few people had put A, D, E, B, C. Great. So someone's given me, more than one person has given me a response. Let me just summarize the 2 or 3 that people have said, and you tell me if this is along the lines that you were thinking. Those of you that put A first and D second, were you thinking, this is quick? So if you tell them, look, I can't do it, they can start finding someone. But then to find the consultant and then discuss the whole situation, that they've asked you to stay on, that you're exhausted, you don't feel it's safe, that they shouldn't really be asking, that whole thing is going to take a long time. And so you thought, I'd do this first, and then I'd do this afterwards. Is there anyone that thought like that? Yeah, quite a few of you. This is the most common reason to lose marks in section 1, is when people think about this as a sequence in time. Because nobody's asking you which order in time would you do these. They're asking, if you are only going to do one of these, which is the best answer? You need to think about each of these options as a discrete or separate option. This is the only thing you're doing, okay? So instead of thinking about the word then, you should be thinking about the word or, okay? If I could only do one of these, and that is my whole response to this situation, and I'm not going to do anything else, which one thing is the best one? Is it D, or is it A, or is it E, or is it B, or is it C? Okay, and the right answer is it's D. Why is that? Well, it's really important you map back to those domains. Remember those 3 domains in the SJT? Okay, just go back to show you the slide. Okay, that empathy and sensitivity, professional integrity, and coping with pressure. Okay, we don't have time today, but each of these is broken down into loads of subdomains, and specific questions will be mapped to testing specific subdomains. But part of empathy and sensitivity, for example, is thinking about how other people would feel about different scenarios. Part of professional integrity is to know your sort of duties, to be honest, to like talk to other people, like patients and so on, with honesty, not to say something that's not true, not to misuse your position in the NHS. Part of coping with pressure is to know your limits, to know what's not safe, to know when to ask for help and who's the right person to ask for help in which situation. Part of professional integrity is to know your role. So one of your roles as a junior is to keep your senior team members informed, right? So look what happens in D. D shows positives for more than one domain. So first of all, by letting your boss know that about the whole situation, they know that there's no junior level cover, that a locum will be there in the afternoon. So they know that, if necessary, they might have the registrar cover, or that, some things might be pushed, things like clinic, but they know it's important they know that there's less cover. Okay. But also, by highlighting that it's not safe, you're knowing your limits. By explaining the whole situation, you can see medical staffing know they shouldn't ask you to stay on beyond your night shift. If you say no, you're not putting yourself and patients at risk, but they might ask someone else. You might not be able to change that, but if you tell your boss, they might be able to change that. They might be able to highlight, you shouldn't ask my juniors to stay on beyond their night hours. Okay, that's not a safe situation. So it actually highlights positives for multiple things. It's the most complete response if that's all you're going to do. Okay, if you look at option A, it's the next best option, in that if this is all you do, at least they know you're not going to do it, and therefore they can try to find someone else, or let the boss know we have no cover, and again, do that. But you see, what it's not doing is it's not dealing with the fact that they've asked you in the first place, which D is. Okay, now I'm going to leave E because quite a lot of you might have put E higher up. Okay, but sometimes if you're finding a question difficult, one of the things, generally I recommend starting at the top and work your way down. If you're finding a question difficult, find the best two, find the worst two, the middle will find itself. Let's look at the bottom two. We all agreed that staying on right now when you're so exhausted that you're barely able to keep your eyes open and you can't concentrate is not safe. Okay, and so do you see, B and C both put yourself and patients in an unsafe situation. It shows a negative for knowing your limits. Okay, and so that's why B and C are both at the bottom. They're both really, really unsafe. However, out of them, why is C worse than B? This goes to something important. The examiners ask you to rank what a good doctor should do and not necessarily what you would do in real life. Okay, and so the difference is that in B, you can see in both B and C, you're being dangerous. So that's a negative. But in B, at least your motivation, all right, is not about personal gain. Whereas in C, you're saying, look, I'll do a few hours, but I want to give me a full day back later. You're trying to make personal gain out of an emergency situation, which you shouldn't do. Do you see the difference? Okay, so this shows another negative. There is a negative here. There's like two negatives here. Now you're left with E. Now, quite a few of you put E higher up. In fact, some of you, not many, but a few people actually put E as their first option. Okay, can anyone suggest what the problem is with E? Why is E not as good as either D or A, but better than B and C? So the problem with E is this, that look, first of all, if you come back in the early evening before your night shift, they don't need you then. The locum is going to arrive by the afternoon. That was mentioned in the scenario. There's no need. But on top of that, now you're coming in the early evening and then you're going to do a night shift. What's going to happen at the end of your night shift? You're going to be overtired. And so potentially there is an element of risk. But do you see why that's not as risky? Because if you come back in the early evening, you're not going to be doing that much because someone else is going to be here. If you stay on now when there is no one else, when you cannot concentrate at all, you can see there's more risk in B and C. That's why these are worse. So do you see, there's some positives and some negatives. This is very negative. This is double negative. This is, you're being safe, you're knowing your limits, but what you're not doing is challenging the inappropriate behavior. Here, you're also doing that. That's why it's the best option. Okay, so the biggest thing that I want you to take away, that section 1, each option is a separate option. It's not about the sequence of time. It's about, if you're only going to do one, each option is discrete. If that's your whole response, is this the best option, or is this the best option, or this? Not the word then. You should be thinking about the word or. So you're comparing it to the one above and the one below. Okay, right, let's move on to section 2. So in section 2, you get a scenario just like section 1, but you get 8 options, and you're not ranking anything. You're asked to pick 3 that taken together make the most appropriate combined response. Okay, so here we go. So you're treating this patient who's diabetic. He's on the care of the elderly ward. He's had a fall. He's got an unexpected spike in his blood sugars in the evening before dinner. And he's got a sweet tooth. He's mentioned this. And you've seen his wife is actually bringing him sweets as a treat. Okay. So I'll close the poll there. So the popular answers are B, D, G, H, and followed by E. But the four most popular ones are B, D, G, and H. These are the four most popular ones, okay? So the correct answers are B, G, and H, okay? B, G, and H. So if you had all three of those, you'd get 12 marks. So maximum score for a section 2 question is 12 marks. If you had one right, you get 4 marks. You had any two of those right and one wrong, you'd get 8 marks. You had none of them right, you'd get 0 marks, okay? So let's go and look at the ones we haven't picked and why we haven't picked them. You see, in section 1, it's not about good and bad. Sometimes they're all bad. It's better or worse. You're comparing, right? In section 2, there are some options that either go against some kind of GMC guidance, or they're unethical, or they just have something negative for any of the 3 domains, i.e. they show negative for empathy and sensitivity, or they show negative for probity, professional integrity, or honesty, or they show a negative for knowing your limits, or coping with pressure, or staying calm, and things like that. So if we look at option A, why can't we get rid of option A? Not many people picked this, but we did have 20 something doctors picked it still. Okay, so what's wrong with option A? It's the word confront. This is your patient, they're in hospital, they're unwell. To confront them about someone else's behavior is a real negative. That's not sensitive. It doesn't show empathy. How do you think they're going to feel? Their wife is bringing them this treat, and now you're confronting them and telling them off. You see, it's totally inappropriate. Discussing, different, but you can see words are important, right? So this is a negative for empathy and sensitivity. That one's out. Option C, hardly anyone picked. If they're not controlled now, if you measure them less frequently, it may get even worse, and it will take you longer to pick it up. So it's not really in the patient's best interest. Okay. Option D and E I'll come back to, because quite a lot of people picked D and E. Between the two of them, about 25% of you picked either D or E, so it's quite a lot. F, see, if you think about how might the patient feel, again, think about empathy and sensitivity. He might really like to have his wife come to see him. He's unwell, he's in hospital. And so while you might be thinking about his physical well-being, someone's psychological well-being, emotional well-being is also important. And so it's a negative for that, but also it's not your role. Knowing your role in the team is an important part of professionalism, right? Okay, this is not a role that you as a junior doctor could decide. Usually, even the consultant doesn't decide this. Usually this is the senior nurse on the ward. The ward manager would decide about who can visit, or the visiting times and things like that. So what's the problem with D and E? The same problem with D is actually the thing that's an issue with E. Why is it that D and E, what's the negative there? Both D and E would constitute a breach in confidentiality. Do you see? Okay, if you drop by to see him while his wife is there and start talking about care and recent results, this is confidential information. It doesn't mention any of the other options that you've taken the patient's permission. Similarly, if you discuss his results with his wife, that's confidential information. He might like to have his wife come, but that doesn't mean he gives permission, and being the next of kin doesn't give you any automatic right to confidential information. So do you see here, knowing what the GMC guidance is about when you can and cannot breach confidentiality will help you realize that D and E, neither of them are suitable. Now, how do you know you've got a section 2 question right? Really simple thing. The key word is and. Remember, it's the most appropriate actions taken together. So read back your 3 choices together, not necessarily in alphabetical order. Add in the word and ask yourself, number 1, does it make sense? And number 2, does it deal with the situation appropriately? So let me give you an example. Does this make sense, first of all? So this is the order I'd do it. H first. Discuss the recent blood sugar levels with Mr. Jackson and explore his diet. You see, you're not confronting him. You're not telling him off about his wife's behavior. You're saying, look, I noticed that your sugars have been really high lately before dinner. I just wanted to find out a little bit more about what you've been having. Let's take the last couple of days. What was breakfast? What was lunch? What was dinner? Any other snacks? Anything else? It's really helpful to find out. Okay. And suggest some sugar-free treats that you might enjoy. Look, as you've got a sweet tooth and your sugars are really high, these are the kinds of things that if you had them, while they might give you, oh, it tastes nice, it's not going to affect your sugars in the same way. And continue to monitor his sugar levels at least daily. okay? Because you notice it each evening, so at least as much, maybe even a bit more frequently, so that if it's going even more out of control, you'll pick it up. Number one, does it make sense? Makes perfect sense. Number two, does it address the situation? Yes, that's how you know you've got it right. So section 2, if you can do that little test, you actually know you've got 12 marks before they mark it. Okay. Right, so for section 2, maximum 12 marks for each question, 4 for each bit that you get right, 0 for any bit that you get wrong. So it's binary. So one of the things is, although half the questions are section 2, 2/3 of the marks in section 1, because each question is worth up to 20. But in section 1, you can never get 0 as long as you select an answer. You can get 0 if you didn't drag any options. If you didn't get to a question, you can get 0. In section 2, you could get all 3 wrong and get no marks. Okay, so remember, it's the most appropriate combined response. You've got to think about the word and. Does it make sense together? Okay. Right, so how are you going to prepare for this? First thing is to understand not just those 3 domains, but the subdomains and how to apply them. To have a good working knowledge of good medical practice and the other core GMC ethical guidance, understand the difference between section 1 and section 2, and then practice questions. Ideally, you want to spend a longer time understanding the why, the explanation, than just doing lots of questions and you just look at the answer, because you're not going to get those scenarios. In terms of ethical guidance, you want to know about the biomedical ethical principles: autonomy, beneficence, non-maleficence, justice, distributive justice, and how they would be applied. The rules around confidentiality, when we can and can't breach, when we have a duty to release confidential information, capacity, advanced refusals, do not attempt resuscitation, end of life care, the ethical guidance on that, Gillick competence, when the Fraser guidelines also apply, consent. So you need to understand that Bolam doesn't apply anymore, but that it applies to other things. You understand the Montgomery standard, the GMC 2020 consent guidance from 9th November 2020, how personal beliefs and medical practice could impact care, financial issues, raising concerns, safeguarding for children and adults. All of this is important because it can be relevant to some questions. Okay, so in terms of, especially for the SJT, for both papers, but particularly for the SJT, if you want to really cover that technique, what can really help is our 2-day MSRA grammar course. So we have 2 full days. They're the 5th and 6th of December. Day 1 is all clinical, a full day of clinical, where we'll do lots of high-yield clinical topics. We will have a full clinical timed mock and go through rapid reviews of the relevant guidance to over 100 clinical topics. Day 2, the whole day is SJT. So we can have a big focus on exam technique. We can cover all of that ethical guidance that you need. We can also do a timed teaching mock and go through detailed explanation from a whole load of scenarios. We've had excellent feedback. We've been running our grammar course for over 13 years, but it was a 1-day course before. This year, because the MSRA is so much more important, because in a lot of cases, there isn't anything else, we split it because a lot of people said that doing half a day of SJT and half a day of clinical, they wanted a bit more teaching up for both. So that's why, and all of the questions in our grammar course are unique to those courses. They're not overlap to any of the online or anything you will see anywhere. So they're 5th and 6th of December. It's 2 full days, 9:30 a.m. to 6 p.m. each day. And we've helped lots of people get really high scores, top 1%, top 5%, direct offers, things like that. I'll tell you a little bit more about that later, but I want to talk, because we're running a little bit over. I need about another 10 minutes to just finish how to prepare. So I want to talk about common reasons for failure. We've boiled this down to 4. We've been helping people prepare for this exam, and a lot of people who are resitting for 13 years now. Since it came about, 2007, they started using this exam in GP, okay? So not allowing enough time is probably the #1 reason. What a lot of doctors do is they wait until they get the invitation. Remember, the invitation is going to come around the 5th of January, but then by that time, the exam's between the 28th of January and the 12th of February. You've given yourself less than a month to prepare. Now, if you weren't working and you spent a month, you could probably prepare for this. But if you're also working and you've got on calls and you've got everything else, it's not that particular subjects are really, really hard. It's just that you need a broad knowledge of so many things for the clinical. That's just going to take time. There's no shortcuts, okay? Underestimating the exam. So a lot of people, they think of this as, like, I often get asked the question, what's the minimum to pass? If you're thinking about that in that way, you've already set yourself up to fail. Because it's not a pass-fail exam like, say, finals is or PLAB is. Your score really matters, okay? It's competitively ranked. It's not your score, it's how you score compared to other people, okay? And so, like, there's lots of people that pass, i.e. they get a rank, but it's not good enough, so they don't get an interview, so they don't get a job. So for things like radiology, where it's only round 1, they have to wait another year, okay? Or they get an offer, but because they didn't rank well, they get an offer in their last choice, and it's not really somewhere they want to go. They don't want to move there, so then they don't accept the offer. You know, if you want your first choice, or if you're applying somewhere competitive, or you're applying somewhere and you haven't got much flexibility, you've got kids in, you know, school, and you don't want to move them, so you can only apply to a few areas. You want to get the best score possible. So don't underestimate and don't aim to pass. Aim to smash it. Go for band 4s. Focusing on just one paper. I've seen lots of people that got a band 4 in one paper, but got a band 1 in the other and failed. Okay. And then lastly, poor exam technique. You can work really hard, but for example, if you don't practice questions to time and you run out of time, lots of people then get a poor score because they didn't finish either paper or both papers. They're both tight for time. So how are you going to prepare effectively? Well, it's really, a lot of it's the opposite. We talked about earlier, you know, active learning versus passive learning. You want to allow enough time to cover the curriculum. You want to have a good understanding of GMC ethical guidance and how it applies to scenarios a junior doctor might encounter. You want to practice those realistic questions and work on exam technique. And you want to do timed mock exams. So, you know, we've got full timed mock exams, 3 for the clinical, 1 full one for the SJT, and then timed mini mocks on our online revision. And then find a study partner. You know, finding someone to motivate you. Have you done a few questions today? What did you learn? Questions that you're struggling with, to talk them over, you know, to share topics in terms of, like, you know, you do a little summary on this guidance, or, you know, let's talk about this question that we're both finding difficult. It's worth thinking about those things. Okay, so we do have a support group for that on Facebook. Feel free to join that if you want to find people to study. That's for anyone applying to any of the specialties that use the SRA. If you're applying for GP, do join the GP training support group. It's the biggest group for people interested in GP training. It's 21,800 doctors on there. Okay, people in every deanery, in every stage of training. There's trainers on there. You know, you can get advice and answers to questions very quickly. So in terms of practice questions, I told you about ours. There's over 2,100 questions, including 202 SJTs, 1,900 and something clinical questions, over 100 hours of learning. And then our bundle. So you get the 2-day course. Lots of people that have done really well, you know, have found the course. We get a lot of people who, for example, failed 1 year, and when they're resitting, they've come to the course and gone from a band 1 to a band 3+, or a band 2, a band 4, and gone on to get their first choice, you know, and done really well, especially for, you know, competitive specialties like radiology, you know, or people that want to get direct offers for, you know, competitive areas like London, or both competitive specialty and competitive area, ophthalmology in London. Okay, so the bundle is the 2-day course and the questions for 3 months, full mock exams for both. If you were to buy all of those separately, it would cost $549. You can get that for $449, but use this code until midnight tomorrow. You can get a further £30 off. So that code will expire. Just to recap, the code will give you £30 discount off the 2-day course, okay? Or it will give you 10% discount off the online revision. So if you go to our website, the 2-day course is right here. So that expires midnight tomorrow. Right, so I'm going to summarize first, and then I'm going to stay back and answer questions. So please do join the MSRA support group. Someone will post a link into the chat. Do join the GP training support group if you are applying for GP as well. Subscribe to our YouTube channel if you want to get this video when it comes out. We will email it to you as well. But also you'll find other videos about the application process, about how to rank, you know, various other things on there. Okay, there's loads of free CPD. So just to summarize, look, it's a 2-part assessment. Both papers are equally weighted. It's important that you give time and importance to both. What you don't want to do is do brilliant in one. And some of you might know that, look, I know I'm good clinically, but maybe you're less familiar with SJT. It doesn't mean you have to spend the same time. You might spend a bit longer on the SJT because that's your area of weakness, but don't neglect clinical. That's what I mean. Like, they're equally weighted. You might spend different times based on what's, you know, your weakness. Remember that whether you get shortlisted to interview or not, and then it carries over, you know, what your rank is going to be impacted by your score. In a lot of cases, if you don't score well, you won't get an interview. And for things like GP, psych, this is 100%. And then for radiology and obstetrics, do brilliantly, you can get a direct offer and not have to do the interview. So, you know, it's not a pass-fail exam. It's a competitively ranked exam. Every mark matters. If you can get 1 more mark than someone, that might be the difference between you getting the last job in your first choice and getting your second choice deanery. So it's worth fighting for every mark, okay? You know, because just passing often isn't enough for you to get a job or the job that you want in either the specialty you want or the area you want. You know, some specialties are more competitive than others because there's less numbers. So focus your revision, practice under time conditions. One of the biggest things is if you haven't already started revision, well, look, you've taken a first step today. You know, I want to leave you with this, that Lao Tzu said the journey of 1,000 miles begins with a single step. Well, you've taken a big step by giving up. I know how precious all of our evenings are, but you've given up an hour and a half to spend with me and the team because you actually care about this. So look, you're already here now. What I would recommend is, if you've not been doing revision, from tomorrow, you've done enough for today, just do a few questions, revise one topic, read a few pages from one of the Oxford handbooks, but do something each day, one step at a time. Before you know, you've climbed the mountain. Come the results, I get an email from everyone here just to let you know I got my first choice offer in my first choice job. Okay, that, just keep going. Please don't wait until after you get the email to book, because by that time you've left yourself only a couple of weeks. That's a huge mistake. So look, you've already you've self-selected by giving up your evening. Just keep that going, keep pushing, keep going, prepare, and you will succeed. So the last thing to say, for those that are leaving, thank you very much for giving up part of your evening. Okay, myself and the whole team at eMedica wish you every success. If you've got any questions, you've got anything that you need support with, you can always drop us an email, find me on Facebook or LinkedIn, send me a message. Feel free to contact me via the Facebook group. We're always here to help anyone that needs it. So thank you very much. Have a great evening. All the best with your exam, and I hope you get your first choice specialty. Thank you so much.